We'll start, sir. 6:30. It is.
Yes. Yeah. Please start.
Good evening to one and all. On behalf of API and ICP Karnataka, I heartily welcome one and all for this virtual program on World Asthma Day. I welcome all delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus RGHS Bengaluru and KVN University Gulbarga. I welcome Dr. Maya, Patron, Dr. K. Govind Babu, Chairman, Dr. Vishwanath, Secretary, and Dr. Ravi Kirti, Central API Member, and Dr. Rashekar, Immediate Past Chairman API. I welcome our guest of honor, Dr. Muruganathan, Past President API and the Past Governor ACP India Chapter, and many other organizations. I welcome our today's chief guest, Dr. K.K. Parikh, sir, Past President API from Kota, a senior most faculty in API, loved by the whole API family across the country, a great academician, a researcher, scholar with many publications and awards and fellowships to his credit, a dynamic personality, and heading now the API House Committee from Mumbai. I welcome our today's speaker, Dr. Ravindra Mehta, a close associate of mine who never said no to any of our earlier invitations, that speaks about his dedication to academics and teaching, a great name in the field of interventional pulmonology, both national and internationally, a renowned faculty, with many publications to his credit. I also welcome our today's chief moderator, our own dynamic national API secretary, Dr. Agam Vora, pulmonologist from Mumbai, worked in different capacities in national API from many years, a great academician, publication done both national and internationally, received many fellowships of various organizations, received many awards, a spiritual follower as well, and participated in many spiritual programs. I also welcome our today's panelist, Dr. Nagarjuna Matturu, a young dynamic pulmonologist working in Yashoda Hospital, High Tech City, Hyderabad, a tertiary care interventional pulmonologist of international repute, with a great name in pulmonary medicine. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As many delegates who have registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम्.
Yeah, we are virtually honoring all our guest faculty for their tremendous contribution to their work done in their respective field in the country. Now I request Dr. Muruganathan sir to address the gathering.
Thank you, Dr. Sangram. It's my great pleasure to be a guest of honor for our program. Always, Sangram involves whole medical academy also in the programs and so on. On behalf of whole medical academy also, I'm very happy to welcome the speaker, especially my good elder brother, Dr. K.K. Parikh, and Dr. Sankar, Dr. Ravi, Agam Vora, Kirti, Rajshekhar, all my good friends. It's always pleasure to be a part of this program because all my brothers from Karnataka, API, and ICP are a very good support for us. And every good day we celebrate. So today, World Asthma Day, we want to sensitize and create awareness not only among the patients but also doctors. It's a good practice to have asthma club among the patients. So I would request all the members to initiate asthma club and make sure your asthma patients have the once in 2 months joint get together so that they will understand better what to take, what not to take. With this, I wish the function all success. Thank you so much for inviting me. In another 2 minutes, I'll fly. My flight will take off. Thank you, Sangram.
Thank you, sir. Thank you for sparing your valuable time in spite of your flight. So now I request Dr. P. S. Shankar, sir, to address the gathering. Kindly unmute, sir. Yeah.
Dr. Parikh, Dr. Agam, Dr. Muruganathan, Dr. Mehta, Dr. Nagarjuna, Govind Babu, Dr. Maya, Vishwanath, Rajshekhar, Ravi Kirti, Sangram, and dear colleagues. We have assembled today to celebrate the World Asthma Day, which is being inaugurated by Dr. Parikh, distinguished past president of API. I still remember my visit to Kota 3 decades ago when he had organized a scientific program. I welcome him. My dear Agam is with us with sheer dint of his hard work and capacity. He has risen to the post of secretary of the API. I am glad he is conducting the discussion. I welcome Dr. Ravindra Mehta, Dr. Nagarjun. Welcome my friends, Dr. Maya, Muruganathan, Govind Babu, Vishwanath, Rajshekhar, Ravi Kirti, and Dr. Sangram, the backbone of this program. A World Health Organization, collaborative organization, global initiative for asthma, GINA, founded in 1993, has chosen Asthma Care for All as the theme for 2023 World Asthma Day. World Asthma Day is held on the first Tuesday in May, and the day has become one of the world's most important asthma awareness and education events. It promotes the development and implementation of the effective asthma management programs. It is being held annually since 1998. The World Health Organization estimates that 235 million people suffer from asthma globally. This theme underscores the importance of ensuring that everyone with asthma, regardless of their geographic location, socio-economic status, or other factors, has access to effective and affordable asthma care. The goal of this theme is to promote equity in asthma care and management and reduce the burden of asthma on the individuals, families, communities, workshop. Worldwide, bronchial asthma is a complex and heterogeneous syndrome characterized by episodes of intrathoracic airway obstruction, airway hyperresponsiveness, and airway inflammation, resulting in episodic occurrence of dyspnea and wheezing, which varies widely over time, either spontaneously or in response to treatment. Asthma includes a heterogeneous group of patients, and attempts are made to find out a common denominator among the situations such as chronic inflammation of the airways, allergy, and psychogenic factors. But the unique common denominator has been shown to be hyperactive airways, which manifest with variable airways obstruction in response to a wide variety of endogenous and exogenous stimuli. Asthma is associated with constriction of the airway smooth muscle, inflammation and mucosal edema, accumulation of mucus, and an influx of inflammatory cells, including eosinophils and neutrophils. Its heterogeneity is exhibited in the precipitating factors, location of airways obstruction, degree of reversibility, onset, frequency, grade of severity, periodicity.
There is something in the.
Yeah, kindly unmute, sir.
No. Something wrong with the
Yeah, probably internet instability, probably. Unmute, sir. Unmute. Kindly unmute. Shankar, sir.
These
Right.
various clinical entities which we are considering, the clinical categories of asthma suggest that the need for classification of asthma as a syndrome rather than a single disease entity. Asthma is a collection of the signs centered on the airways on which diverse trigger factors act to bring about airway hyperreactivity and reversible airway obstruction. Two main components of the airway obstruction, bronchospasm and inflammation, require treatment with bronchodilators and anti-inflammatory agents. The aim of treatment is to achieve and maintain normal airway function. Controlling and treating asthma has been an age-old challenge for the clinicians due to its heterogeneous pathophysiology and the variable response to treatment. A complex interplay of environmental, physiological, and genetic factors that dictates the pathological process. Therapeutic regimens aim at acute symptoms relief and the long-term control of the airways inflammation. Majority of patients respond to a combination of glucocorticoids, beta agonists, and leukotriene receptor antagonists. These are administered in a stepwise manner, reducing the exposure to the trigger factors such as environmental allergens is also an integral part of the asthma management. These solutions require lifetime regimens as they afford only symptomatic relief. Many of them have well documented side effects such as glucocorticoids and long-term dependency. Biological therapeutics aim at targeting the inflammatory cells and the mediators produced that play the key as the humanized monoclonal antibody and the anti-cytokine-based therapies targeting the key interleukins involved in the airway inflammation and the anti-tumor necrosis factor antagonist, they also play an important role. These novel innovations are expected to bring about effective solutions in the therapy of asthma, though they have drawbacks and side effects. Further research and development is expected to lead to their improvement. The increasing practice of precision medicine and the description of the asthma phenotype are the driving factors for these things. And we have assembled here today to hear the experts on this important disease. I am happy to join in the inauguration of this program. As every breath counts, we have to support the World Asthma Day. Thank you.
Thank you, sir, for nicely elaborating the basics of asthma. Now I request Dr. Govind Babu, Chairman API Karnataka, to say a few words. Kindly unmute. Unmute. Kindly unmute, Govind Babu.
Okay. Yeah. Thank you, Dr. Biradar. I think we can name Dr. Biradar as king of webinars. He's been doing so many of these and so effectively. So I must thank you for this and for asking me to be here on the inaugural function. My medicine professor used to say that, air is the only thing that is freely available. And even if that the patient cannot get, then it is such a bad thing for the patient. So we must see that every asthmatic gets the air that God gives him freely. I think Dr. Shankar, as usual, has covered everything that we need to know. And I don't think I'll waste any further time. Thank you for having me here. And let's listen to the proceedings.
Thank you, sir. Now I request our chief guest of today's function, Dr. K.K. Parikh, sir, for your inaugural address.
Good evening, friends. It's really a great pleasure to be here on this platform of Asthma Day. Respected Dr. P.H. Shankar, guest of honor, and one of the most respected and senior chest physician, not only in India, but he is known all over the globe also. And thank you very much, sir, for reminding me of your Kota visit and from Bombay to Mumbai to Kota. And this shows the commitment and the towards the API and towards the profession also. Thank you very much, sir. The guest of honor, Dr. Muruganathan, my close friend and a close associate in API, guest of honor for today's CME. And thank you so much, Dr. Muruganathan, that you are with us on the flight. And this is what we need, the commitment from our colleagues for the profession and dissemination of knowledge. Dr. Maya, veteran of API Karnataka, Dr. Govind Babu, Chairman API, Dr. Vishwanath, Secretary API, and Dr. Sangram Brother, the program conductor, a very effective and very many organizing so many meetings, scientific meetings of API and ICP. He is member of governing body and a very effective person in the profession. Dr. Ravindra Mehta, we have got very learned speakers. Dr. Ravindra Mehta, senior pulmonologist of great repute. Dr. Agam, a very dynamic organizer or a secretary of API, like my younger brother, very known as a very great academician and especially in pulmonology. Dr. Mathura, the senior pulmonologist, and my friends who are attending today's meeting. Friends, let me compliment and congratulate the Karnataka chapter of API for organizing such a important meeting on the Asthma Day and to enable all our physicians and medical fraternity to disseminate the knowledge and to update themselves for respiratory problem, especially for asthma. Friends, we all know that asthma is a big problem, and that's why WHO has made this this Tuesday as the Asthma Day to make more awareness about asthma in the public. And so it's a big challenge for all of us to increase the awareness in the public about asthma so that we can prevent so many complications of asthma in the future also. Today we have got very learned speakers which will be telling us and updating us about the asthma on this very important day. And thank you very much, the organizing committee members, especially my dear Sangram brother, for inviting me on this time and giving me this great honor to be on this platform. Thank you very much. Jai Hind, Jai API.
Thank you, sir. Thank you for sparing your valuable time to join and address the gathering. Now I request Dr. Agam Vora to take over for further proceedings, as all the guest faculty have already been introduced. So it is your platform, sir. Dr. Agam, kindly conduct.
Good evening, everybody, and I thank you, Dr. Birdar sir, for inviting me at this August gathering. And when I see my teacher, Dr. P.S. Shankar there, when I see my mentor, Dr. K.K. Parikh there, and when I see such huge, fantastic gathering, I could not resist myself but to attend to this program. And we have the talk by Dr. Ravi Mehta. So I would request Dr. Ravi Mehta to give his presentation on Asthma 2023, State of the Art. After that, we would have panel discussion. I would request all delegates to please pen down all your queries, all your questions, and I will not leave Ravi till all your queries are solved. That is my assurance to you. Thank you very much. Over to you, Dr. Ravi Mehta.
Kindly unmute, sir. Unmute from your side.
Thank you so much. I think initially it was a permission. So, well, thank you so much for Dr. Biradar, Agam, all the seniors of our August organization here for calling me. I'll just share my screen and we'll start the talk. Is the screen visible?
Yes, yes.
Okay, 1 second. Okay. Right. So first, yeah. So it's nice to be here, and a decent context was made for World Asthma Day and highlighting the importance and now looking at what's new in this disease in 2023. So that's my topic, and I have around 30 minutes, right, Dr. Biradar and Agam?
Yes, you may. Yes.
Yeah. Thank you so much. Okay. So we've titled it State of the Art. And today's flow is going to be, we cannot walk away from any disease without talking of its burden. And then we talk of recent salient changes because it's a very accomplished crowd who keeps in touch with common disorders. And so we'll see what's new in the field. We'll use some cases to understand the difficulties faced in complex and severe asthma. We'll discuss the Indian perspective, which is so much of a part of our lives, and then we'll summarize the whole talk. So the burden of asthma, as you can see, critical illness in India is it always used to be cardiovascular disease, and now lung disease is a close second and taking over also in many areas. You can see how it's rising now. Oncology, liver and kidney is also there, but lung diseases are a predominant part of what we have to deal with. In asthma, the numbers are quite shocking. These are older numbers, and as we've hit our 1.4 billion, the largest in the world, as they say, we have to probably up the ante for these numbers. We have around 13% of the global burden. So technically, literally 1 in 8 asthmatics are present in this country. That's a whole bunch of cases. Obviously, the mortality will be high when you're looking at all the problems, which leads to the discussion today. And this is also likely underestimated. And at least 1 in 2.5 of deaths are coming from our country. So extremely concerning and drastic statistics, which need obviously a lot of work to be put in. And here comes GINA, the Global Initiative for Asthma, which has been there for many years. And they made things either interesting or complex, depending on how you look at it. They've made asthma into steps. And ultimately, when you look at this algorithm gives us a interesting, methodical, but somewhat complex way to deal with this. And on the right side, as the font gets smaller and smaller, more and more challenging medications such as biologics are coming in, which we'll address in the course of the talk. Now, what is salient? There's a lot to be talked about, but in the time given to me, I thought we'll highlight what are the changes, especially for those of you who've been around for so many years. First was the short-acting beta agonist particular class, a new look. And we all know that these were the game changer initially. When you dial the clock back 25 years plus, they were the mainstay of asthma therapy. They were amazing. They gave instantaneous relief, and anything which gives instantaneous relief will not leave the spectrum of disease therapy. So they were used as monotherapy, not only by doctors, but patients who take their own call, of course. So they loved it. And sorry, 1 second, just put this on silent. And 30 years of SAVA, we basically had to deal with the fact that we prescribed it left, right, and center for all the reasons talked about. But what we did not understand, which was highlighted in the last few years, is that the whole pathophysiology of asthma, which is A, inflammation, B, inflammation, and C, inflammation, and D, bronchospasm, has not been addressed by these drugs. And so this not only led to the fact that we are not impacting the basic disease process, but we don't do anything preventive with this. It is just a patch-up thing. It is just putting out a fire. It is not addressing anything to do with how this problem came up. And that's why papers galore came up, where they said that overuse of short-acting beta agonist is the first trail was higher mortality. And that was supposed to be because of ignored asthma and because of cardiovascular issues by and large. And then came the fact that slowly everybody began to realize that beta agonist managed asthma is uncontrolled asthma. Inflammation, which we've talked about for 3 decades, is not being addressed. And so that became the major mantra. And basically, GINA 3 years ago said, no more SABA. And that was big thing over there because they said that ICS, the inhaled corticosteroid, should be given to all asthmatics because they go together. either in combination with a long-acting agent, preferable. And now, of course, they're coming with the SABA because the SABA may make sense when piggybacked onto ICS, but no SABA alone, which was talked about, neither as rescue. So this became a major change over there. And interestingly, it has hit the practice world much faster than one would have imagined. So what do we use now? No more SABA. The agent which comes is the long-acting agent, long-acting beta agonist, which is formoterol, and low-dose inhaled corticosteroid. So classically, anti-inflammatory combined with the long-acting beta agonist, bronchospasm taken care of, and inflammation taken care of, long-acting for 12 hours taken care of, dose escalation possible. So that became the new modified prescription for what we have to do. Since this was fitting with these two entities, these two particular products, the ICS budesonide and the LABA formoterol became the game changer. The dose was here, and finally there's doses. How much can you give? Well, formoterol, you can say average 56, but you can stretch it to 72. So for most preparations of 200 by 6, it will come to something like 8 to 10 or stretch it to 12 puffs a day. But then you run out of budesonide. So budesonide 2000 micrograms and formoterol 56 to 72 was the range. So this became the new recommendation. And how did this align with old thinking? So that's concept number 2. SMART was a concept which came, I think, roughly 15 years ago. And SMART stands for single maintenance and reliever therapy, where the whole thing was, again, why are we using two products? For example, if you are using drugs like salmeterol, fluticasone, we had to give a different drug for rescue, which was the SABA. So they said, why not use a single drug? And somewhere over there in this combination has been the genesis of why SABA left the picture. So in that, again, formoterol budesonide, standard therapy given for maintenance and the same drug for rescue. So that has led to, I think, this current recommendation. And the reason was what we talked about. Formoterol has properties of quick action, longer duration, and now comes the pathophysiology that it may have a complementary anti-inflammatory effect on airway edema and mast cells. And 1 + 1, when combined with budesonide, it may give the impact of 3 to 5. So this is what SMART came in with. SMART had variable penetration. It was taken up very quickly by some. The others who swear by the effectiveness of fluticasone and the power of anti-inflammatory like fluticasone. So people use SMART not so smartly, but at the same time, there were many who held on to the old combinations. But these two are the major changes which seem to align with each other when it comes to practicing asthma therapy now. Now comes the interesting stuff, which can be either interesting if you look at the severe asthmatic, so it can be very, very onerous when you look at the fact that molecular biology, immunology, and biologics, those three words which were hovering around other spaces like rheumatology and oncology, now enter the respiratory space. And if you want to enter the respiratory space, enter into asthma and COPD, because that is where maximum impact is and maximum patients are. And so words like customized medicine and precision medicine have come in, which we'll also talk about a little later. So then it comes down to, is this talk worthwhile at all? Do we have severe asthmatics in large numbers, which is a problem? Or has this inhaled corticosteroid paradigm defined everything else? So it turns out 3.7% of patients who have asthma have severe asthma, which require GINA step 4 to 5. And they will have poor symptom control. At the same time, despite doing all the steps of right medication, right dose, the compliance, and good technique. So those are the ones who actually are severe or difficult to control or complex asthma. Those terms are debated as to their finesse, but ultimately this is severe uncontrolled asthma despite all due diligence. So that is the definition. LTRA we'll talk about also. Theophylline is plus minus, used a lot in India, maybe some in the UK, and some of us will like it a lot because we've been used to it. But currently it seems to be hovering on the absolute brink of to use or not to use. It comes down to by and large controller medications, ICS, LABA, LTRA. At the end of it, we are still stuck with what to do with the uncontrolled asthmatic. And so the tools is what we outlined. If you have that gentleman sitting in your clinic who's spastic all the time, and it's as difficult for him to come to you as you to treat him, that double paradigm, then you go through a checklist, which I'll be showing this maybe once or twice. Confirm the diagnosis. And one of the main thing asthma clinics do is that they try to make sure that it's actually asthma. It's not something else, especially the common mimics are COPD and congestive heart failure and some other similar entities. Nowadays, everything with lung got treated for tuberculosis. Unfortunately, that's changing, but all that has to be looked at. And then you have to figure out how bad it is, which we talk about. And then comes that customized precision word, which was talked about. And the clinical relevance of that is try to figure out the phenotype. Phenotype is putting a label onto a patient so as to establish his clinical laboratory profile so that we can treat him with a particular type of medication, and also sets the stage for tons of research and discussion. So these are the reasons to do all that. And like I said, that's what's led to the mantra of what we talked about. So the case which got us thinking are these complex cases, by and large, where we had this 58-year-old male. This is Bangalore, so that's what we'll have. No bad risk factors. Came to us with a nightmare situation. By the time he came to us, OCS, oral steroids were going on forever, mild comorbidities, the usual symptoms, ABPA plus minus. He was treated in the US where he spent some time, but not sure at all. OCS goes on and on. No other risk, no other issues at that point. But he would had a pretty horrible life. If anybody, though that subset which you see in your clinic, why does it happen to some people? We have no idea, but he was one of them. The CT scan, the X-ray was unimpressive except for hyperinflation, splayed ribs, and clearly a suffering person's X-ray. And the CT scan was extremely illuminating because it confirmed the fact, first of all, that there was not much of COPD, other diseases, or ABPA, but there was minimal bronchiectasis, not plus minus proximals, but again, no ABPA categorically, which had probably is the hallmark of a chronic asthmatic. Most chronic asthmatics, because of mucus plugging and because of recurrent attacks and infection, will go through this incipient early bronchiectasis. You can see his lung function was not the best at all. He had, moderate obstruction all the time. And we did the usual. We said, this we can look at. Let's try and get everything going, jacked up all the doses. And then comes the humbling part of healthcare, where you realize how little you know. Progress or lack thereof, he just could not taper his steroids. Though he was great with inhalers, IT professional, worked in leadership roles, and then the steroid taxes infection, bad infection, re-looked at ABPA, and also speak to our colleagues in PGI who are very good at it. They said, nope, no categorical ABPA. And then the cycle, which makes it so difficult for patient and doctor. Exacerbations, OCS, infection. All this went on and on. The patient gets on the bandwagon of trying to compete with the doctor. He looks at therapies. That's when bronchial thermoplasty is hitting India. The first one came with our colleague, Dr. Pattabi Raman. We were also looking at whether we should procure thermoplasty. Before that, we said biologics. Omalizumab has been there for a long time. And being educated and smart and researching, he was given both options of BT versus biologics. Patient himself has access to pulmonologists abroad. He decided to go for thermoplasty, which he underwent in Singapore. And post-BT, he was asked to reduce his OCS. He did. Life was good for 6 to 9 months. Came down to methylprednisolone. He preferred this drug 4 milligrams. And lung function got better. The serial PFTs, as you can see here, showed FEV1 went from 1.97 to 2.3 to 2.46. So it was really going well, and the obstruction part was coming down. But why are we bringing up this case in this forum? Because there's always a problem. The bronchial thermoplasty part started to go, get into a little trouble, though he had initial excellent response. And maybe it's the nature of the disease and not the modality. And you'll know why when I go through the whole case. He had an exacerbation requiring treatment with, again, the same combination. And now bronchiectasis started to go up, which is going to funnel the infection part of it, which was worry. And now we're wondering whether the tapering of steroids, those of you who love to look at this Sherlock Holmes sort of thing, post thermoplasty led to unmasking of an underlying ABP, which we thought was not there. So it was a versus bronchiectasis related to procedure versus bronchiectasis related to infection. We repeated it again, unable to categorize as classical ABPA, but we have eosinophilia on steroids. So is this uncontrolled asthma? Is this ABPA? Is this EGPA? The new entity, which was, the name of Church-Strauss has become EGPA. Impossible to figure out with no markers positive. Continued on triple inhalers. And again, the story of exacerbation started off. So what do we do with this? And sorry for the small font. I can only take advantage of that in an online session. Again, the same thing. Now, the new thing which was coming into the spectrum was same thing was going algorithmically. New thing was look at inflammometry, as we call it, airway inflammometry. And there it was absolute eosinophil count, fractional excretion of nitric oxide, which had hit the ground, and if at all rule out sputum eosinophil, very few have, most of us don't have it, and IG we were following anyway. And then you classify them into that entity called Th2 type, which is an inflammatory phenotype, eosinophil driven, versus a non-Th2, which is the dry, absolutely bland, neutrophil driven entity, which doesn't respond to inhalers and so on, and try fancy stuff like microlights or non-biological therapy like thermoplasty. So this is all the biologics used over here. So AEIOU, this is especially for the younger people. The mnemonic is diagnosis confirmation. So go through the due diligence of environmental aspects, give the right inhalant, the right dose, look at comorbidities, and look for ABPA. So come back to our interesting gentleman. Omalizumab started after thermoplasty to augment it. Again, he improved, but as we said, nothing seems to be working long for him. Are we going to get into trouble? His Medrol doses have come down. Again, the problem over here is he gets exacerbations. That time, mepolizumab has hit the market, available as Nucala in this country, and that worked again. So third entity working for some time or the other. And then, of course, mepolizumab also, there was a breakthrough, and this whole science can be talked about completely separately. Biologics, inflammometry, how they are used, and so on. This is where asthma is getting more and more both interesting, analytical, and complex. So he then again started to get exacerbations, and then Bendrali had hit the market, and there are certain advantages of Bendrali over Mepoli. And currently, for the last year or so, he's been on Bendalizumab and on hardly any OCS. I think he takes around the equivalent of 2 milligrams every other day, which he ups and downs, but he seems to be quite happy with the quick responses on the fact that World Asthma is Day. Dr. Mehta, what are you doing to disseminate it? The PFT, you can see here, we've gone through that, the procedures. For example, here we had post-thermoplasty, we had a jump. Then we went down and started omalizumab, and then mepolizumab, and then ultimately on bendalizumab, he's doing decently well. So we've had improvement, but we've thrown everything in the book on an analytical platform based on his clinical progress. So this is where he's got a much better quality of life. One more case like this very briefly, which will set the stage for a interesting discussion. 50-year-old, and look at the age profile of all these people. Again, on maximal therapy, not doing too well. Basics done, as we talked about. So again, you've done your clinical workup, you've done your due diligence, comes back to biologics or thermoplasty. Here, we don't have any of the Th1 phenotype features. We don't have inflammatory markers. We don't have the IG, which is high. The eosinophil count is less than the 150, which is the bare entry of biologics, 300 being ideal. So there was nothing. So this is bland, non-eosinophilic, likely neutrophil-driven inflammation over there. And so her phenotype is adult onset. Her endotype is T2 low, paucigranulocytic. Forgive me for the technical terms, but that's inevitable now. And the biomarkers are negative, fits into thermoplasty. And so we offered a thermoplasty, and she is doing very well now. So now it's been close to a year. Pre-thermoplasty, we had FE1 of around 38%, and we pushed the boundaries in trying to do it. And now she's sitting with 48% with good quality of life and exacerbation free. not requiring healthcare. So these are two complex cases, one a nightmare, one a difficult case, which had different options. So what we touched on was these two entities, and we'll build up on that, and we'll build up this science in the next 5-10 minutes. And then we'll talk on other interesting aspects, which we were trying to highlight today. So before we go very fancy and taking out the big guns, is there more things we can do for these people? And triple therapy has been the mantra for the last 3 to 4 years, if I'm not mistaken. And the triple therapy paradigms either use one inhaler, which is the last 1.5 years, or multiple combinations called the open triple. A lot of stuff on devices, which I may not be able to cover today. So management, back to the GINA slide. When you reach here, you're looking at the complex asthmatic where you've closed the ICS LAMA, you're adding on the LAMA. Question is triple, which is combined triples, a single inhaler, or by and large split inhalers, and then this entire biologic game, which we have highlighted in our patient story and we'll talk about. So this is what we're going to focus on. So in that triple therapy, by and large, it's clear that LAMA came in a big way. It leads to not only improvement in lung function, but reduction in exacerbations, the two mantras of therapy. And then these options were there. Currently, which hit the market are fluticasone, Vilantol, umeclidinium in one. And now there's so many of them from the generics which are patented to the local molecules, from the drugs which are patented to the generics. Now we've got so many triples out there that now it's going to be a problem to figure out who's got what. So Gina said it can be given as a separate, LAMA can be put in as a separate inhaler or in a combination, and they've left it as an and or. But by and large, the recent papers which have come, it says that triple compared to dual is definitely better, which is the Gina step 5 paradigm. And most importantly, single versus multiple for a single word compliance. So if you take multiple, it's going to be at least one inhaler. For example, if it's formoterol budesonide, it's twice a day. And if you add, say, tiotropium, glycopyridine, it's once a day. So you have 3 hits over the minimum. If those 3 hits are a compliance issue, akin to diabetes, blood pressure, and you reduce it to a single inhaler, turns out you get better outcomes. Is the better outcome because of just compliance and the fact patients like it? Or is it because of some synergy which comes when you put them together? It's something nobody knows. It's going on the story of compliance and data at this point. So that is a single inhaler triple therapy paradigm. Now, biologics and thermoplasty, which we touched on, and apologize for these pictures. They're pretty, so they look attractive, but they are always challenging. This is to revisit T1 and T2. So basically T2, the TH2 prototype, which is there, is allergic asthma or non-allergic eosinophilic asthma. So by and large, it is driven by the eosinophilic process and may have manifestations both in either the nose, in the lung, and other organs such as the skin quite commonly, and rarely in the GI. But this is T2 high and this is T2 low, also called TH1 and TH2. So don't get confused with the terminology, just stick to one and see. But this is all we try to do. Eosinophil driven asthma or non-eosinophilic asthma. And based on that, everything has come out, including inhalers, biologics, pathophysiology research, and so on. So biomarkers which are used, we've already touched on this, is IgE for the TH2 high, FeNO for the TH2 high, eosinophils, which the magic number now came to 300, now pushed down to 150. So for first time, we're looking very carefully at blood eosinophils, which are a surrogate for airway eosinophils, which are caught on sputum eosinophilia assessment, which we can't do. So we now extrapolate blood eosinophils to the airway eosinophils causing problems. So this is where we are right now. And the immune responses based on these led to this plethora of biologics. So omalizumab came here as an IgE-based binder. And then the burst of drugs came here. And this complex picture is shown in a lot of asthma presentations, where you have dupilumab, reslizumab, mepolizumab, benralizumab, And of course, the latest one to hit is the TSLP inhibitor, and we talk about all that. So this is where we are. It's a tongue twister to pronounce all of them, but once you get used to them, it's much easier. So most of these, this entire collection is available for the allergic phenotype, which is the Th2 driven, which is the eosinophilic driven, diagnosed by clinical eosinophilia and pheno. So if I'm confusing you, I'm sorry, but we'll try and walk through this because I promised to give recent aspects. What is the latest one? When you're fed up of all of them and the eosinophilic component is not working and you're looking at thermoplasty, lo and behold, the Wall Street Journal a few months ago said, here is a game changer. Tezepelumab, a human antibody that blocks thymic stromal lymphopoietin. So if you see this here, this is the entity here, a very proximal part. So if you block this, you're going to block every part of this cascade. So this drug is supposed to be something which can be used for any phenotype, but of course, nothing is a panacea. Literature is coming out, so it's one more addition, broader spectrum, as you've seen in other parts of science, and still to come to India and put its mark on the total spectrum of asthma therapy. I'll skip this for now, and the only drug which is clear in pregnancy is omalizumab. In India, we have omalizumab for the last 12 plus years, I think. We have mepolizumab for the last 4 to 5 years and Bendrali for the last 3 years by and large. Only advantage is this seems to be more potent. It's required to be given every 2 months after the maintenance dose, and currently is has an edge over the others when it comes to therapy in the country. Now, thermoplasty. We touched on thermoplasty. What is thermoplasty? Thermoplasty is basically the fact is that you have smooth muscle in the airway, which is hypertrophic, which causes both narrowing and exacerbation. And if you can reduce that smooth muscle with radiofrequency ablation, you may do the patient a lot of good. So if this video plays here, it's playing well, you can see it, I think. Okay, it shows the animation of the thermoplasty procedure.
With normal breathing, excess
where
muscle,
you can see
together with inflammation of the...
That by and large, there is hypertrophic smooth muscle. This smooth muscle not only causes baseline narrowing, but also causes increased narrowing when there's an exacerbation. And so if you can do something about it, it'll make a big difference. So bronchoscopy-wise, a thermoplastic catheter is put in, which uses radiofrequency ablation strategies used in many parts of medicine. This is the approximation and this is what is done. And this can make a big difference in trying to reduce this smooth muscle to a much more manageable aspect, which can not only give baseline luminal happiness, but also will lead to decreased worsening and exacerbation. So this is the whole concept of thermoplasty. And the other things they talked about is it can cause cholinergic neural damage, which is good in asthmatics, and new therapies are coming for that also. And of course, the flow part improves. And a fancy theory is that gene networks important in asthma pathogenesis may be impacted by thermoplasty. So this has been thermoplasty, and now when I'm concluding, I'll talk of some trivia, interesting trivia, but practically relevant. An old drug visited is Montelukast, described like water, right from, I think, if I can use a little liberal language, ward boy to asthma to pharmacist to anybody, and everybody is using Montelukast indefinitely. So it turns out that there is a increased odds of adverse psychiatric outcomes. So that little sadness, depression, worry is not intrinsic. It may be after your drug. And so you have to monitor mental health issues in these patients, which led to a boxed warning in 2021, which has hit a lot of important forums. And you have to understand that you just cannot prescribe the drug. So our senior Dr. Om Prakash used to say, this is a drug with no effect, no side effect. But now you can say that it has probably some effect, but more side effect. So this has to be rephrased when it comes to Montelukast. Indian perspective, oh God, we are a potpourri of problems because we deal with stuff which Westerners may not see enough. Delayed contact, they come much later. Worried about all our therapies. Don't use them and keep stopping them. Don't come and meet us. Exacerbation so difficult to capture. Nobody will sit and chart them until the provider goes obsessive about it. Preventive aspects, the environment is just going from bad to worse. Thermoplasty, it's so difficult to get it done even when you talk about it, and cost points. And this is a lifelong disease which can throw you off. You plan a trip to Ladakh Leh and you may suddenly be in a hospital. So that's a problem. From the provider point of view, we struggle with all these, right? From evaluation to treatment to now, pharma also is actually not making it easy. So many combinations, so many dose points. And if Ravi Mehta is going to tell you all of them matter and you have so many things to do as a doctor, how are you going to sit and master all that? So we usually reach to familiar favorite prescription. Easier name, easier prescription, familiar looking guy, some guideline, let's just go and do that. Time to try and put all this so challenging. And then ultimately, the knowledge gaps which we're trying to bridge today, because interestingly, in the last 4 to 5 years, the asthma pipeline on the information highway is racing at this point. Triples, combinations. We have so many ICS, LABA, LAMA, different drugs and so on that we're very unique in an over-choice phenomena, and economics will always play a role. So what is the push now? Asthma and specialty clinics, which is now somebody who can put all this together and put attention to all that. So, a lot of us have started this. We here have started one after COVID, which have put energy into the whole process. So to summarize the whole talk, despite significant advances, we still have a long way to go. We are now putting it into the phenotyping algorithm, find out your clinical, look at your basic markers, eosinophil, and if possible pheno, catch the exacerbations, and don't allow things to get worse. We showed in those cases. Gina is saying that when you go right shifted to stage 5, single inhaler triple therapy, it seems to have an edge over high dose double therapy or multiple inhaler triple therapy, largely adherence driven. Saba is exiting, may come back in some way with ICS, but currently exiting. Monte Lucas now suddenly a benign looking fellow has a small caution which has to be exercised. And the new kids on the block saying my share is there is thermoplast, is biologics. 3 of them and more will come. And thermoplasty, which is there, and it may not last long because there's some issue with the company, but by and large is there as an option in around 15 to 20 centers in the country. And it's reserved for the non-T2 phenotype, which you've done because you've done all this due diligence. Bottom line, it's information evolution. It's a classical example of personalized and customized medicine. So we know a lot now, but there are many questions which still to be answered. We have never seen so much energy, enthusiasm, research, and productivity in asthma. And we hope that this talk sets the stage for more understanding, which will lead to better asthma care. My gratitude again and again to Dr. Biradar and everybody else who has called me. Thank you for the attention, and I will stop sharing my screen.
Wow. Ravi bhai, that was one of the fantastic presentation, and you give beautiful overview of the entire topic. Yes. Aman.
Yeah, go ahead.
Thank
Sir.
you, Dr. Mehta, for that. Sorry.
Yeah.
Thank you. Yeah. Thank you, Dr. Mehta, for that fantastic presentation. You've given super overview of the entire topic, and you've given us various newer therapeutic options. I have with me Dr. Nagarjun also, and we have a lot of questions here for you. So both of you, please get ready. And I'm going to shoot at least 10, 15 questions that I can see on my screen. So I have a first question that comes from Bangalore, and I have another Dr. Mehta from Bangalore who's asking me this question. And Ravi bhai, he has this simple question for you. As a physician, we still, even after years of experience, find it difficult to differentiate asthma from COPD. Would you tell us your clues to differentiate asthma from COPD, Ravi bhai?
So I think it comes down to, again, the basics of clinical history supplemented by spirometry. The clinical history, the classical story of an asthmatic is that of somebody who starts a little younger in life, whose story may have that of a family person with a similar problem, who has childhood onset asthma, which either went away or did not go away and persisted later in life, who by and large is unlikely to have a history of smoking, who's not in a profession which is leading to environmental exposure to his airways, and classically gives a description of sheer normalcy at times, which is great life, with episodic worsening, which again goes back to his normal situation. And over the years, that gets worse and it becomes more problematic. The negative part, we should not have smoking because that confuses us. and by and large, you should have triggers over there which should make the person worse. So if you have that prototype, that gives the answers of a typical asthmatic. A COPD, on the other hand, by definition, used to be a smoker who has a progressive history, older in age, and has more symptoms of persistent symptoms with hardly any normalcy, hovering around cough, sputum production, and basically whose life is deranged for good. Now, with the non-smoking COPD becoming predominant, we have now seen that the non-smoking prototype also can get into this. And for those of us who didn't want to break our head, they came up with this entity called ACOS, which is come and gone. It's no longer that activated. So this is the easiest way to distinguish. Then you do a spirometry, and the spirometry, if it's actually totally normal and shows a great bronchodilator response, you're more in favor of asthma. But in a patient who's clinically okay, if you have a fixed obstruction, which is poorly bronchodilator responsive, then you will favor COPD. And that requires more analytics than the simplistic description I'm giving you. And if you go ahead and you have access to a CBC showing, eosinophilia or an inflammametry showing a higher FeNO, that would favor COPD. And if you go ahead and do that elusive word, but now common called CT scan, and you see emphysema out there, that's most likely COPD. So bits and pieces I've given you, and this should probably help to at least put some analytics into our mindsets.
Wow, great. And I'm so happy, Dr. Biradar. I've got delegates from Bangalore, Mangalore. There's a place called Shimoga, Udupi. We've got doctors who've logged in from Kalaburangi, Vijaypura, Mysuru, Davangiri, Hampi. I'm so happy. And yes, Dr. Nagarjuna, there's a lot of confusion regarding this asthma and COPD overlap. I understand everybody gave us two different scenarios. We have one clinical scenario of asthma and one clinical scenario of COPD, but many a times there are overlapping symptoms. And there's a lot of confusion when it comes to Gina. Gina proposed the term asthma COPD overlap syndrome once, then they talk about asthma COPD overlap, then they remove this term. Would you please enlighten us? What is this asthma COPD overlap, and is this term valid?
Hi, sir. Hope I'm audible. I
Yes.
think the entity asthma COPD overlap is being debated every year. There is a new recommendation that it has to be used, not to be used. But in real life practice, I think this is something which does exist. So as Dr. Mehta sir has said, you do see two distinct phenotypes sometimes, that you may have a person who's actually fitting into a typical asthmatic or a typical COPD. But many times in clinical practice, you have these people whom you cannot actually label them as either purely asthma or purely COPD. So I think this is the group where we can clinically call them as asthma COPD overlap, irrespective of whether the international guidelines say us to use or not to use. So some typical syndromes where we can use this term ACO. In our practice, what we normally say is, one is this long-standing asthmatics. So most of the asthmatics, they start off by having a typical reversible airway disease, variable symptoms. But then over the years, what happens is they tend to behave more like COPD. They tend to have more of fixed airway obstruction. They do not seem to have good days and bad days. They will lose that sort of seasonality and they start behaving like COPD. So that is called as remodeled asthma or asthma converting into COPD. That is one subset. Second subset is those people who have risk factors for both. So asthma is a very common disease. You might have a person who's genetically predisposed to develop asthma, but also is exposed to an environmental toxin. So he might be smoking, he might be exposed to pollution, he might have some occupational history. So he will have features of definitely both COPD and an asthma. So a smoker with asthma, again, it will be very difficult to actually call him a COPD or call him an asthma. So that is one group of people where you have risk factors for both. You might have a person who is genetically predisposed to asthma, having allergic rhinitis and all those things, but also he is a smoker and he's also having a risk factor for COPD. So that is the second subgroup where clinically you see a lot of such people. The third group is COPD with eosinophilic predominance. So you have a person who is actually looking like a typical COPD, elderly gentleman, smoker, fixed airway obstruction, but also seems to have a significant eosinophilia, having a lot of wheezing, So again, this is one subset of people where you are actually unclear whether it is pure COPD or he might be having some asthmatic component. So these are three broad groups of people in the clinical practice where we see and where we are a little confused as to whether to label them as asthma COPD. So this entity definitely does
Perfect.
exist. Yeah.
And Dr. Biradar, if I may ask you, what do you feel in Karnataka? What must be the prevalence of this asthma COPD overlap? Would you unmute yourself, sir? Sangram sir.
Yes, sir. Yes. Yeah, but, we commonly see both COPD and asthma overlap is quite common.
Quite common, true.
Acute
And
exacerbation.
especially when we don't have access to good spirometries, and especially when there is so much of environmental pollution and people who have not taken their inhalers properly during their earlier phases, asthmatics, as Nagarjuna Bhai said, they've become now fixed obstruction with environmental pollution and smoking. On top of that, they're behaving more like asthma and COPD overlap. And I also probably echo the same sentiments as Sangram sir is saying. In Mumbai, I also see significant proportion of this patient having asthma COPD overlap. Ravi Bhai, are you there?
Yeah, very much.
I was just, then why are you not seen? Why are you hiding? Okay. So then
When
Ravi
Agam
Bhai,
is on stage, all else pale away.
As I said.
Ravi Bhai, we heard a lot about these phenotypes in COPD and asthma. Today, we wanted to ask you about these phenotypes in asthma. So, what are these phenotypes? What different phenotypes you see, and what would be the clinical relevance of this phenotyping?
Well, that's what we just talked about. That the phenotypes by and large come from 2 points of view. The one is that if you're a research person, then you need to look at that because it's easier to talk about. And the second is clearly the therapeutic targets. So there is clinical phenotypes, and then there is basically the phenotypes based on the treatment you're going to plan. And the clinical phenotypes have gone into many categories, such as the obese phenotype, the exercise-induced asthma phenotype, the allergic phenotype, the non-allergic phenotype, the elderly phenotype, and so on. And that's based by and large on clinical observations of what is going on. The treatment part of it is now come down to whether whatever you are, you have to now put them into a T2 high or a T2 low. It just comes down to that, because therapeutically, all the others may not have much relevance at all. They get T2 high, which we talked about, which means they have a TH2 helper process driving their asthma. So now you are putting this unique combination of pathophysiology, 10,000 papers of asthma, current understanding, and getting it to the bedside, which most fields don't allow us. Then you will be looking at that person's allergic component, which is your clinical part, TH2 high. Then you're looking at obviously the historical aspects which help you. Then you're going on to straight other aspects like nose, skin, which again defines allergic phenotype. Then the triggers, which also tells you more about it. And then comes the inflammatory, which we espoused frequently, which is the eosinophilic component, the pheno, and IgE. So that is the main thing to look out. If all of that is dry, desiccated, and non-pinpointable, it goes into non-T2 high. Now, here is where the controversy or the fun starts. There's a whole bunch of people who believe that most of it is T2 high. There is hardly anything which is non-T2 high. And most of the time when we don't have a T2 phenomena, meaning allergic phenomena or eosinophil-driven phenomena, is because we haven't looked hard enough. So this is where we are. But for practical purposes, you have to define that. Who is the non-T2 high? People will ask, well, it's typically the dry, bland phenotype, which is, in at least practice, we have seen it's typically an obese person who you try to give inhaled corticosteroids to, and you're trying to figure out that dyspnea is part of asthma or something else, and you really cannot, your medications are not impacting them at all, but somehow you catch the whole trail of asthma in them. So those are the ones who have been fitting a lot. The other ones who've been fitting into that have been the elderly one. So elderly, obese are two subsets we have seen, which are at least have a tinge of non-T2, which we can think about.
Great. So Dr. Harun, I'm sure you got your query solved. He had a question about differentiating T1 and T2. Dr. Nagarjuna, let me ask you this question by Dr. Abhay Singh Devra. He wants to know how would you look at the efficacy of LABA and fluticasone as ICS versus LABA and budesonide as ICS? That means, how would you compare this budesonide and fluticasone? Dr. Nagarjuna?
I think I missed the question. So the question was
Oh.
comparing salmeterol, formoterol, and fluticasone budesonide.
Yes. So then LABA, one LABA ICS combination versus the other LABA ICS combination.
Okay, I think the stark difference is as far as the LABA is concerned. So as Dr. Ravi sir had said, both salmeterol, formoterol are long acting, but formoterol is fast acting also. I think that is the most important difference as far as the combinations are concerned. So now the current trend is for most of us to use the so-called MART therapy, smart therapy, which by definition includes a formoterol based because it is fast and long acting. As far as the efficacy is concerned, I would put both formoterol and salmeterol to be equally efficacious. The only difference being that formoterol can be used as a reliever and a controller, whereas salmeterol can be used only as controller but not as a reliever. Then if we have to compare fluticasone and budesonide. Again, for now, you have to remember that there are two fluticasones. You have fluticasone furoate, you have fluticasone propionate. Okay, the conventional fluticasone was fluticasone propionate, which is to be taken twice daily. And budesonide was there. Fluticasone furoate is the newer inhaled corticosteroid, which is most potent of all the inhaled corticosteroids, and it is the longest acting. That is fluticasone furoate. In fact, the newer ICS LABAs, vilanterol and fluticasone, comes to fluticasone furoate. So they have to be taken once daily. And the dosing of fluticasone in it is much lesser. 100 of fluticasone furoate is equivalent to 500 of fluticasone propionate. So that is a different molecule. If you have to compare fluticasone propionate with budesonide, which is the conventional twice daily ICS, though the pharmacokinetics of pharmacology says that there might be some difference as far as the lung retention and other parameters, and for all practical purposes, I would say that fluticasone propionate and budesonide would go hand in hand. But fluticasone furoate is the newer, highest potent inhaled corticosteroid. I think that is how I would say.
No, perfect. What you said is absolutely right. Trust me, by and large, all these inhaled corticosteroids are equally good. If you use them in the equipotent dose, they by and large have similar efficacy. Of course, there would be individual variation. There are some patients who may not do well on a particular combination. There are some patients who would do great on that combination. And yes, before you label somebody as uncontrolled, you must change their inhalers. That is what is the current recommendation says. You change over from one inhaled steroids to other inhaled steroids and reassess them at the end of it. It may so happen that a small subset of patient may respond. To be that, Ravi bhai, how often have you done that? How often, when you see your patient is not doing well, before considering him for oral steroids or before considering him for biologics, have you done that? Have you changed one steroid to other steroid? Have you changed one LABA to other LABA? Have you changed one delivery system to the other delivery system?
Yeah, absolutely. It happens all the time, and that is what's called the steps between GINA. That between 1, 2, 3, 4, 5, there is a 3A, 3B, 3C, 4A, 4B, 4C, which is not talked about, and that is based first of all that A, B, C, D has to be done, and it is so difficult to do. Right, looking at everything from asthma control to triggers and so on. Once you do that and you're convinced, then you're looking at either a more potent steroid or some sort of synergy which is better. So yes, we will convert one double to another double. We do use the smart strategies more. So my personal preference has been to convert salmeterol fluticasone, if it's not working, to smart, because somewhere we believe that earlier action of formoterol with the larger dose of budesonide may make a difference. If that doesn't work, then the newer ultra LABAs have come in now, that once a day, which is vilanterol fluticasone, as Nagarjun was saying, or now the mometasone has come, indocaterol mometasone. So this is where I told you, we either make it fun or crazy when you start trying to keep a track of all these doses. But we are trying to use those for compliance, because we will never know until that inhaler monitoring comes. So again, new exciting stuff is down the line. You'll have some sort of device on the inhaler which will release a signal when the inhaler is used, and that e-monitoring is going on in the West at this point. So till then, we try the Ultra LABA LAMA, which is a once a day. And if that doesn't work, we go to triple. Triple has been also shown better than double, and single triple, as we said, has been shown to better than multiple triple. So there is a fine line which can be done before you ultimately enter the whole arena on the whole field of biologics and thermoplasty.
Great. So initially we were looking at our asthma patients as, I remember the older classification of looking them as intermittent and persistent. Persistent we would subdivide into mild, moderate, and severe. But soon we realized when you put these patients on treatment, the response could be different. And then came this concept of controlled, partially controlled, and uncontrolled. So when you initiate treatment, you look at the response in some time. If you feel this patient is doing extremely well, which happens in only small subset of your patient, you would continue same treatment. If they're uncontrolled, probably then comes this interesting different therapies like biologics and thermoplasties that Ravi Bhai spoke about. So with that, Dr. Nagarjuna, tell me, what are your exact subgroup of patients whom you would consider for biologics?
Yes. So I think biologics are only for that small subset of people who would qualify for the definition of a severe asthma. So, but in India, even this small subset is a huge number. I think this is what I would say. And when will I consider biologic is what I think the algorithm which Dr. Ravi sir had shown is you don't just because a person comes and says, I'm having symptoms despite using inhaler, you don't jump and put in a biologic. You have to go through the complete checklist. So at our severe asthma clinic also, the 5 steps which we do is one, always reconfirm the diagnosis of asthma. Never take it on the face value. If a person says asthma, it is asthma. It might be actually something else also. Second is inhaler. Again, very important to ensure whether the person is taking it or not. Complaints, very difficult sometimes. You have to be smart enough to pick up non-complaints. And the technique. Technique is again very, very, very important because if you correct the technique, many times the people start becoming better. Third important thing is to treat the comorbidities. So asthma is a disease which has comorbidities. So you have to treat allergic rhinitis, you have to treat reflux disease, cut down the weight. Obesity is another important thing. You should ask them to cut down the weight, and many severe asthmatics actually become better. Then OSA and psychosocial component, anxiety and depression. So if you treat the comorbidities, another subset of them become better. Then ask for triggers, both at the home and at the workplace, and try to address them to the best possible. There might be some triggers which are unavoidable, but what can be avoided have to be avoided. So once if you do all these things, and then the person is using the medicines, from double you have to go to triple. So before going to biologic, always we give them an add-on LAMA, either glycopyrronium or tiotropium. And despite which the person is not good or not well controlled, I would say, is when you would want to use biologic. The main indication for biologic is to decrease the exacerbations. So you want to decrease the number of times the person is getting steroids, or you want to improve the quality of life. So once you do all the checklists, you confirm diagnosis, rule out triggers, treat comorbidities, check for the inhaler complaints and technique, given already triple therapy for asthma, still the person is uncontrolled, then comes the role of biologics or thermoplasty. I think this is how we do.
Excellent. Excellent. Very well said. So whenever a patient is not doing well, you will look at those factors which may have been missed. First of all, reconfirm the diagnosis of asthma. Do the spirometry again. Do their clinical evaluations again. Look at the factors this could exacerbate asthma. Like you may have missed allergic rhinitis. You may have missed associated GRD. You may have missed associated sleep apnea syndrome. You may have missed associated pulmonary hypertension or any other comorbidity for that matter. Once you address both things, then you look at patients' compliance and you look at patients' inhaler technique. Once you're convinced about those things, then comes this patient's severe asthma. If this severe asthmatic is of eosinophilic or atopic subset or variety or phenotype, these are the patients that can be considered for biologics. So as of now, we've got biologics only for this small subset of severe asthma who are eosinophilic or atopic. So Ravi bhai, then what subset of patients are there for your bronchial thermoplasty treatment option that you gave us?
So that's what, as we talked about earlier, Nagarjuna also very nicely put down, a few patients are left only. I think it comes down to 2 ways to look at it. If you go by a pure world where there is enough medicine for enough money for biologics and there's no problem at all, then most of the world will be on biologics with few patients reserved for thermoplasty. the non-T2 phenotype, as we talked about, or the failure of biologics. And we've showed that in our case also, that sometimes it can happen. But in a world where you are trying to figure out cost economics, it may turn out that since there is a longer term use of biologics, and there is a question in the chat box asking about how long to give it, then there is a case made that one thermoplasty with a 70% chance of improvement till 5 years may be a much better thing than doing biologics. So at this point, few patients qualify for either biologics or thermoplasty, and a small patient percentage of them go to thermoplasty. But otherwise, down the line, with the new, this may change every year or so, because with tezepelumab, which we talked about, it's possible that hardly anybody will be going for thermoplasty.
Great.
I think the problem is, Agam, here that we never explored all this in India. We
Dr.
took
Sheila Chakravarti has a very interesting question.
Yeah, we took somebody else's science and followed it. If you look at the economics, the preferences, the compliances, and the follow-up, it may be that this thing would have been completely looked at differently if it was studied in India. And, Nagarjun can also give his thoughts on that. Yeah.
Yeah, I think that what you said is very correct. If you look at from the economic point of view, thermoplasty would be much cheaper than the eosinophilic biologics. But again, I think the cost of biologics also is going to come down. I think now, definitely, I think several companies are ready to,
interesting.
to start the
Dr. Sheila Chakravarti is
biosimilars.
a very, yes. So the question is, after how many days of treatment would you call it as a failure of treatment? Dr. Nagarjuna?
Yes. So I think this
So
is
it is in both
very,
perspective. One
very,
is, when would you call it as a severe asthma? And second, when would you, if you put somebody on biologics, when you call it as a failure of treatment? I think she's not clarified, so I would give you two different scenarios.
okay. So I will address it in two aspects. So first is for the inhalers. So when you change a dose
Yes.
or add a new inhaler or change the device, how soon can we decide whether it is working or not? I would say we should wait at least for 2 months. So not faster than 2 months, at least wait for 2 months or 3 months preferably, and then decide on stepping up or stepping down. That is for the inhalers. Now, if it comes to biologics, so you have started a person on biologic, when can you decide whether the biologic is acting or not acting? I think for this, the time duration is 6 months. For omalizumab, it is 4 months. For anti-eosinophilic biologics, it is at least 6 months. So you cannot say the biologic is not working before giving it for at least 4 to 6 months. I think this is the time which we have to remember.
Fantastic. So by and large, when you're looking at control or uncontrolled, if patient is deteriorating, that is taken as exacerbation and that is treated on a different line. So patient is not doing well, probably you'll wait for 3 months, reassess them at the end of 3 months. If they are still not doing well, probably that is the time to label that as a failure of treatment. And when it's biologics, don't be in hurry. Minimum of 4 months is what is required to assess. At the end of 4 months, if there is symptomatic improvement, if there is reduction in steroid dose, if there is reduction in hospitalization, probably that is success of treatment. Otherwise, it can be labeled as failure of treatment. And then the last question that I have from Dr. Abhay Singh is, what is the present recommendation of GINA as the duration of biologics to be used? Dr. Nagarjuna, how long would you consider using biologics?
There is no answer for that. I think worldwide, whatever data is there, after giving biologic for a particular duration and after stopping, what happens? You have this data for omalizumab, you have this data to some extent for Mepoli also, that the people will start losing the effect of biologic. So for Omali, there is data that if you give biologic for 5 years, 6 years, and then stop, after 3 years, 50% of them are back to where they were. Similar is true for Mepoli and Benrali also. See, what all of these are not changing the biology of the disease, they're only blocking the pathways. So as long as the drug is there in the body, it will act. After that, it is not going to act. The basic pathophysiology, the basic biology is going to come back again. So biologics, I think this question every patient will ask, sir, kab tak lena hai? How long we have to take? I think we have to be very, very honest in telling that at least take for 6 months. If you are better, then we will continue for several years and then we will decide. So I think it's a very difficult thing for the patients that there is no end point to these biologics.
So, Ravi Bhai and Dr. Nagarjuna, tell me, correct me if I'm wrong, in about 7 or 8 patients where I put them on biologics, who did well at the end of a year and a half. And then we've stopped biologics. It was a conscious decision taken, taking multiple parameters into account. And somehow their control remained much better after that for quite a long period of time. Maybe these are the patients who are more disciplined. Maybe these are the patients who are, very, they have taken biologics and they know if they don't take treatment properly, they may have to go back to biologics and their compliance could have been better. Those many factors may be there. But what's your experience? Have you felt that after a year and a half of biologics, you could successfully withdraw biologics and maintain them only on conventional treatment for asthma? Ravi bhai, you first and Dr. Nagarjuna after.
So that's been challenging, Agam, because truthfully, most of the patients who've gone on biologics have been that clear class of people who are looking for quality of life and are not so worried about cost. So for that class of people, to tell them to stop has been very challenging. And we're just going on and on at this point because there is happiness and we have not taken it off. So I have very little experience with taking off, but I'm aware of the literature. The literature is short lasting. See, the thing which may happen is that people believe biologics may cause reduction in their inhaler dosage, not substantiated, may happen for the duration of the biologic, but long-acting not known at all. People believe that biologics will lead to definite improvement and no exacerbations. Again, doesn't happen on it. It just reduces the number of exacerbations. The third only thing which may be coming to make the whole spectrum different is in the next 3 to 4 years, it's possible they're working on long-acting biologics. The drug will last 3 months, 6 months, and so on. So it's possible you're looking at 2 injections a year, and we've seen that in so many other things, like we're looking at rituximab, infliximab. Infusions go on forever. In angst-pond, you don't stop it easily. In rituximab is going on for so many other fields going on forever, lupus and all. I think we're entering that era, the late entry of respiratory medicine, particularly asthma, with specific biologics given long-term for predetermined endpoints. And then they'll try to put in things like reduced inhalers and all, but not categorical.
Great, interesting. Dr. Nagarjuna, your views?
So I think, as Dr. Ravi sir had said, a true severe asthmatic would remain a severe asthmatic. So once you stop biologic, I think he would maybe take some time, but he would come back to his original course of the disease process. I think person who improved without a biologic probably had some correctable factors and which
he never
had been
required
corrected
biologics,
during the course
possibly.
of therapy. This is how I would put it.
Correct.
I think now we have
interesting. So that probably. Okay. I've been getting signals from Dr. Birdar that I have overshot the time. So I would ask for a take-home message from both of you. So to begin with, Ravi bhai, from you.
I think the whole theme today is to highlight this entity on World Asthma Day, bring it to the forefront. The bottom line is asthma is changing. Regular asthma is being looked at differently. Severe asthma is looked at very, very differently. It's time to put more understanding, more energy, and more focus into it. And that may impact on this disease. Otherwise, it's heading for an explosion overall, looking at the escalating numbers. So very interesting time in science to make an impact in a disease which actually has a very high prevalence and is there in respiratory medicine.
Great. Dr. Nagarjuna?
I think there are two things I would say. One is the era of SABA is almost over. Even now we see a lot of SABA prescriptions. I think we should all stop prescribing SABA monotherapy. As Dr. Ravi sir had said in the beginning also, now it is the era of inhaled corticosteroid, the ICS plus a LABA, either as given a SOS or regular. I think that is there. If you see the GINA algorithm also, from step 1 to step 5, you have only one inhaler, Formoterol ICS. In step 1, step 2, it is as to be taken whenever required. In step 3, 4, 5, you should take regular and SOS. So I think the era of SABA is almost over now as far as asthma is concerned. That is the first thing. Second is, again, always remember the basics. I think if we give the correct inhaler at the correct dose, correct technique, correct compliance, 99% of asthmatics will become better.
Yeah, finally, Dr. Agam, your
Thank
take-home
you.
message. Yeah.
Thank you so much, sir. We've come a long way in our understanding for asthma. Life was very simple when I was student. Asthma was all about spasm, and all I would do is put them on salbutamol tablet, aminophylline tablet, and inhalers. Whenever you give them, they would not want to take it. Last 40 years, have been real game changer. We realized it is not only spasm, but it's inflammation. It does not require only SOS treatment, it requires continuous treatment. We started with inhaled steroids, and now we've realized it's the treatment mainstays combination of beta agonists and inhaled steroids. And as Dr. Nagarjuna said, gone are the days when you put them on either only salbutamol or only inhaled steroid. It is a time to put them on combination therapy. Time is again moving from that simple guideline based therapy to personalized therapy. It is no more that you follow that step ladder pattern. But all those patients who don't do well, you've got various therapeutic options. If you choose the right patient, probably these biologics would do wonders. If you choose the right patient, this bronchial thermoplasty, yes, could do wonders. So please choose your patients correctly, give them the right therapeutic options, and yes, it would be game changer. I must thank Dr. Biradar and the entire API Karnataka branch for giving me this opportunity. It was my dream to be on the same stage where I have Ravi Bhai there, where I have Dr. Nagarjuna there, where Dr. Biradar is the organizer, and I am there at Karnataka. So though I hate being here on this virtual platform, I would have preferred, loved being there, meeting Dr. Shankar there, meeting Dr. Birdar there. But then, till that happens, thank you very much. Thank you everybody for joining. It's only your presence that makes the program a real success. And I must thank each one of you for sparing your valuable time and being here with us. Thank you, sir.
Yeah, thank you. Thank you. Before I request Dr. Vishwanath to propose vote of thanks, I thank Dr. Ravi Mehta, Dr. Nagarjuna, and Dr. Agam for sparing your valuable time. I just wanted one comment. Are there any Indian guidelines for our practicing physicians?
I think Indian guidelines are there for all
Are
the
there any, sir?
diseases.
Ravi Bhai?
Not really. Nothing. I mean, there's guidelines were there a few years ago, I think, Nagarjuna.
Yes, yes. It's an old one. It is not an updated one. Yes, correct.
Yeah. And I think if you see the fact that a lot of action has happened in the last 5 years, it needs to be updated, because if you go by what was there old, then you will probably miss the current boat for asthma therapy.
And one more last thing is, how about the artificial intelligence coming into your way of future management?
You want to take it, Nagarjuna, or should I?
No, you please take it, sir.
Well, AI, I think Dr. Biradar is going to come and make a difference. Probably, as in medicine, technology comes last to medicine, one sometimes feels. Similarly, AI will come a little later, but it's coming. As you know, that the NEGM AI rounds, they're talking of chest radiology, diabetic retinopathy, there is an approved tool. So I think if we are able to classify asthma therapy into objective parameters, it's very possible that a good deal of the evaluation and will be done by AI in the future. The easiest part of AI, which we'll see, is that we're going to have all these inhalers with clear e-monitoring. That will make quite a difference. And over time, I think if we can collect databases which are very robust, then you'll have a lot of that. Will that improve asthma therapy? It's quite possible. So the writing on the ground is very clear. If there is anything which is systematic and which can be put into a definable, absolutely objective algorithm, the machine will do it as good, if not better.
So the other thing where AI has come is interpreting spirometry. I think that is another thing where people are confused. You have algorithms, and I think there is data that AI tools do better than some physicians in interpreting spirometers.
Okay. Dr. Vishwanath, kindly propose a vote of thanks. Secretary of
Good
API.
evening, sir. Good evening, all of you. At the outset, I thank our distinguished speaker, Dr. Ravindra Mehta, sir, for giving such a wonderful talk. Sir, we know how busy you are, but still you are able to come and explain so many points from severe asthma, bronchial thermoplasty, use of these monoclonal antibodies. Thank you very much. And also, I thank our excellent moderator, Dr. Agam Vora, sir, our Secretary General of API, and our other panelist, Dr. Nagarjuna. It was really a very interesting, discussion, helpful for clinicians. That's all I can say, because you dwelt upon a lot of clinical aspects. As usual, I thank Dr. Sangram Biradar, sir, for his excellent moderation. I thank all the delegates for participating in this. Thank you, one and all. Thank you, sir.
Thank you, sir. Thank you, one and all. Thank you, doctor. We'll sign off. Thank you. Good night.
Thank you.
Stay safe. Stay safe.
Bye-bye. Bye-bye. Bye-bye.